We're delighted to have you at today's event on facility fee reforms and how states are tackling excessive hospital outpatient charges. To kick things off, I want to thank our event sponsors, West Health and Arnold Ventures, for their commitment to improving the affordability and quality of health insurance coverage. There are few issues that are more challenging and complicated, and they've taken it head on. Both organizations have been particularly supportive of work related to the issues we will be talking about today. I also want to thank everyone who's here today, particularly after the Senate Finance Committee rather inconveniently dropped major legislative language on us at the end of business hours yesterday. I appreciate all of you recognizing how important this topic is, even as we continue to fail to see Congress take it up. I also want to note a couple of quick logistics. First, the event is being recorded. We'll be posting the recording to our website and we'll email it to you as well. Second, there will be an opportunity for you all to ask questions of our forthcoming panel. When it comes time, just raise your hand and someone will come with a microphone to you. All right, before we get to our panel, however, I'd like to offer some brief background remarks to help level set, both with respect to the problem at hand and the range of policy solutions that are available. And so, do I have a clicker or do someone will advance this for me? Great, thank you. All right, so on to the next slide. Over the past 25 years or so, we've seen a rise in hospital outpatient departments as the primary locus of care. Go to the next slide. Thank you. This is driven in part by medical advancements that have allowed surgeries and other procedures traditionally performed on an inpatient basis to move to less intensive settings. At the same time, hospitals have vertically integrated so that a growing percentage of outpatient care is performed in settings that hospitals own rather than in unaffiliated independent practices. This includes a lot of routine services for which there's no medical need to be in a hospital setting. While the shift from inpatient to outpatient settings is generally cost effective, shifting from independent settings to hospital settings means paying more for the same service without evidence of improved outcomes. Can we go to the next slide, please? Thank you. This difference in price based on the type of setting where care was provided is referred to as a site of service differential. And as the slide shows, it can be pretty significant depending on the service. To the next slide. Thank you. Site of service differentials are driven by a couple of factors. First, it is common in both the commercial market and Medicare for hospitals to engage in a practice known as split billing. This refers to the generation of two separate types of bills for a single service or visit. A professional bill covering the time and labor of the doctor that treated the patient, and a facility fee covering a hospital's overhead costs. Compared to independent practitioners, hospitals generally get paid a lot for their overhead, which can encompass many things beyond the costs directly associated with the patient who is getting care and getting billed. For example, a hospital might use that facility fee revenue to cross-subsidize a host of other less lucrative or non-revenue generating services like the ER, the NICU, 24/7 security. Facility fee revenue also may be covering the overhead cost of fancy amenities, generous compensation for the hospital C-suite. On the commercial side, we also see site of service differentials because hospitals and health systems can leverage their negotiating power over private payers to extract higher reimbursement rates than independent doctors or surgery centers can get. So you can expect to see higher charges from those hospitals with more market power on whatever commercial claims they submit, split billed or not. On to the next slide, thanks. In any case, these site of service differentials are increasing total healthcare spending. On top of that, the opportunity for greater revenue by providing care in a hospital setting encourages more vertical integration, exacerbating the problem. For consumers, higher spending means higher premiums. Site of service differentials and split billing also can result in consumers paying significantly more out of pocket based on how facility fees are processed and treated by insurers. And quite understandably, consumers can be pretty surprised and upset when they get these hospital bills for routine appointments or lab tests. And some, particularly those who are less financially secure, may avoid care if they anticipate facing these charges. Behind the scenes, there are a few other relevant circumstances of which to be mindful. First, while facility fee billing certainly contributes to vertical integration, it's not the only motivating factor, and there are a lot of reasons, including low payment rates, high administrative burdens, that can make it hard to maintain an independent practice these days. We also have a private health insurance market that is failing us on cost containment for a lot of reasons, including purchasers often being in a weaker negotiating power vis-a-vis big hospitals and health systems, insurers and TPAs lacking strong incentives to use what leverage they might have to lower prices. And on this topic, somewhat mind-bogglingly, payers might not even know where care took place based on the information that's contained on a claims form, and thus can't factor that into their negotiations or payments. And that lack of location data on claims also means that researchers, policymakers, others don't know where care took place. On top of that, we also commonly lack a lot of insight into what hospitals or health systems are engaging in facility fee billing, how much revenue they're collecting from this practice, how insurers are covering these bills, and other relevant hospital financial information. And of course, hospital circumstances vary widely. Some are doing very well, some are doing very poorly. Many are very worried about Medicaid cuts right now. And the effects of any reforms may depend on a hospital's specific circumstances. With all that in mind, I'm going to turn to options for reform, starting with Medicare, where site of service differentials largely persist under the outpatient prospective payment system, OPPS. Here, lawmakers and agency officials have eliminated the site of service differential for a very, very small percentage of services, represented in the yellow and orange on the slide. For these few settings and services, the Centers for Medicare and Medicaid Services have reduced the OPPS hospital payment significantly. So the total paid for service in an HOPD is the same as what's paid to an independent practice. But there's obviously still a lot of services for which site-neutral payments don't apply right now, and there's a lot of proposals to change that. Most notably, the Medicare Payment Advisory Commission, MedPAC, has long recommended adopting site-neutral payments for all outpatient services that can be safely and appropriately provided in an independent setting. Numbers vary, but we're generally looking at more than $100 billion in savings over 10 years for a reform of this magnitude. Much narrower reforms have also been proposed in Congress, and some have gotten traction and bipartisan support, but nothing has made it into the current budget bills, much less cross the finish line. On the commercial side, states are leading the way, hence why we're all here today. But state interventions to date have looked pretty different than what I've described being proposed in Medicare, in part because there isn't an administrative fee schedule to adjust in the commercial market. States have to deal with negotiated rates and billing agreements between hospitals and payers. Most of the reforms have been relatively light touch. Consumer disclosure requirements, some cost-sharing protections, public transparency measures, including hospital reporting requirements and billing transparency reforms to fix that location data issue I mentioned. More aggressively, some states have opted to prohibit hospitals and health systems from charging facility fees for certain services, like evaluation management services or preventive services. Importantly, and as I expect our panel will get into, facility fee prohibitions get rid of split billing, but do not necessarily eliminate site of service differentials. So hospitals could renegotiate their contracts and make up for lost revenue for the regulated services. And so to address this concern, we see policymakers are starting to think about more comprehensive reforms for the commercial market. As we see revived interest in hospital rate regulation more generally across the nation, we're seeing blue and red states alike. Some people are beginning to explore the concept of commercial site-neutral payment reforms. At a high level, these proposals are aimed at regulating outpatient prices to eliminate the site of service differential and potentially prohibiting split billing along the way. But there are many ways to do this and factors to consider, as advocates and policymakers in New York State in particular have been digging into. And so on that note, I want to hand things over to our incredible panel to elaborate on their efforts to pass and implement an array of different facility fee and hospital outpatient billing related reforms. And I'm just delighted to tell you that our panel will be moderated by Dan Weissmann, host of an Arm and a Leg Show podcast. Dan and his team have been doing a tremendous job shedding light on why healthcare costs so much, including multiple episodes on hospital facility fees. In his work, Dan really elevates the patient and consumer perspective and brings home the real world impacts of our broken system. And I'm so pleased and honored to have him guide our discussion today. And for our panelists, we have an amazing collection of leaders on this issue at the state level, including Meg Garrett-Reed, Executive Director, the Office of Affordable Healthcare from the state of Maine, Charles Miller, Director of Health and Economic Mobility Policy for Texas 2036, and Claire Brockbank, Director of Policy and Strategy at the 32BJ Health Fund in New York. Their full bios are in your brochures, and I'll let them show you for themselves just how knowledgeable they are about policy, politics, and all the weedy details that this issue raises. So please join me in welcoming and learning from these great panelists and get your questions ready. I'll let you guys take it from here.
Like, which one is me? Yeah, it's me. Hi. Hey there. Thank you so much for coming. Thanks, Christine. Thanks to the Center for Health Insurance Reforms for having me and us. And we'll get right to it. Yeah, my name's Dan Weissmann. I'm a reporter. I'm come out of public radio, and I make a podcast these days called An Arm and a Leg, which is a show about why healthcare costs so freaking much and what we can maybe do about it, as we say on the show. And facility fees kind of came up right away. I've been making the show for about 7 years. And in one of the very first interviews I did, I talked to Sarah Cliff, who was then a reporter at Vox. She's now at the New York Times. And she was wrapping up a year-long project where she asked readers to tell her about their emergency room bills. And that project had kind of been kicked off by hearing from one reader who was like, yeah, my baby had what turned out to be a hangnail. I took her to the emergency room, and the bill was, I don't know how many hundreds of dollars. And most of it was from a facility fee, which is a term that Sarah learned when she started reporting that story out. And I was like, well, that's darned interesting. We kind of kept an eye on that. We heard from lots of listeners about it, and including one woman who went in for a colonoscopy at a new provider and was told it would be like 3 or 4 times what she'd ever paid, and that most of that she found out was going to be for a facility fee. One of my colleagues did some digging and found that that practice had been recently acquired by, in that case, a big investment firm, because it's not just hospitals that have kind of discovered this as a source of revenue, which led her to an investor newsletter that was guiding investors towards this very sort of thing in GI practices, thanks to it being the golden age of older rectums. We continue to hear about stuff, especially including from our colleagues at KFF Health News. We partner with them. They had a story, for instance, about a woman who was charged $800 as a facility fee for a telehealth visit, and a woman who came back for an injection she was used to getting her doctor's office, got the same injection at the same doctor's office. Instead of paying a $30 copay, she was charged $350 because the hospital had decided that this was a hospital facility and they could charge that kind of money. So last year, we asked our listeners, tell us as many stories as you can. And dozens of people did. And we ran a couple of episodes telling those stories. And the most shocking one was a woman who found a way to avoid paying an $8,000 facility fee for an operating room fee for a procedure that wasn't going to take place in an operating room. But everybody had stories of one kind and another. And a more typical was a story that Christine helped us report out from a woman who, suddenly started seeing these fees on her bills and was curious, should I even be getting charged for this? And Christine helped us dive deep into her insurer's rules and advisory notes and found that she shouldn't have. But by that time, her HR department was kind of tired of hearing from her, and she didn't want to bother them anymore. So she left that fight for another day. So that's why I'm so happy to be here, because this continues to be a super interesting panel. And I want now to start asking people who have actually been doing things, because one of the other things that came up in all that reporting was, well, where the action is in states. People are doing things and finding ways to make a difference. So I'd like to start by asking everyone, I'll kind of ask you in turn, starting with Meg, about kind of how this issue got on your radar, and then what have you been able to do so far? What has been your adventure, and where's it kind of landed you to date?
Yeah, thank you, Dan, and thank you to the Georgetown team for hosting this great panel. Excited to talk with you all. It's a perfect transition, actually, because the way that this came onto our radar in Maine was reporting. There was a reporter in the summer of 2022 who did kind of an in-depth story recounting some similar experiences by consumers in Maine receiving bills for a variety of different services in different settings where they were really stunned by the total cost and by the expected out-of-pocket costs. So that led a member of our legislature to introduce legislation sort of generally banning the use of facility fees in all settings. That legislation and sort of the conversation around it made clear that sort of more, I think, understanding was needed, that there wasn't necessarily clear definitions for the terms being used or a common understanding of the problem. So the legislation itself didn't move forward, but the legislature did start a task force and sort of tasked us and some of our colleagues with diving into the issue and doing more work. And one particular interesting piece that sort of resurfaced during that conversation was actually a very similar debate that had happened in the state of Maine back in 2005. So it was before my time, but I'll do my best to recount my understanding of what happened from the records, which is that was around the time that some provider practices were beginning to be acquired by hospitals and health systems, and legislators and our insurance regulator were hearing from consumers with that really classic experience of, I went and had a service in a setting one year and was charged one amount. The next year I went and it was a totally different number after my provider was acquired. So the legislature actually took action at that time to pass a law referred to as a standardized billing law in Maine, which actually requires that any service that's provided in an office setting be billed for on a professional services claim form, the CMS 1500 that Christine described, and not a UBO4, a facility or institutional claim form can't be used. So that's really broad language that's different than a lot of approaches. It doesn't speak at all to the physical location in the sense of, doesn't matter even if it's on a hospital campus. If it's a service provided in an office setting, it should only be billed using that professional claims form. So I think that breadth is advantage for the approach, but disadvantage is it does leave a lot of room for interpretation. It wasn't super specific and also kind of existed in both insurance and hospital statute. So there wasn't a really clear kind of oversight or enforcement authority included. So it was great to revisit that and bring that back to folks' attention. And we wanted to look a little bit closer and kind of understand how that law was still working in practice in Maine. So our colleagues in the Maine Health Data Organization, which is our all-payer claims database, did a big sort of data report. The first one came out about a year ago or a little more than a year ago, looking at claims for a set of services, office visits, behavioral health care, outpatient services, and radiology, and examined how often are these two different claims forms being used. And what we did find was in the vast majority of cases, it looks like folks are following the law. Generally, that those services were billed using only a CMS 1500 form. Interestingly, we saw actually very few cases of both of the forms being used together. We saw more where just a UBO4 was being billed when a CMS 1500 was not, and it really saw not a lot of distinct patterns, but some outliers is what I'd say. So not totally uniform compliance with the law, but to the extent there were issues, it was kind of driven by specific providers. So that caused us to kind of take a step back, say, we want to understand this issue a little bit better, but in general, we think that the law as intended in terms of addressing just facility fees, is working fairly well in the state of Maine. And I know others will talk about the bigger picture. And I think that's kind of the point we're at now is thinking more broadly about prices and other issues outside of specifically the facility fee context.
Thank you so much. That is super interesting. Charles, can you pick up with your story?
Yeah, so we encountered this issue. We do a lot of work at the state level, talking to legislative offices about what we call our healthy market strategy, how to make healthcare more affordable. And as other folks who are kind of involved in this policy line of work know that sometimes other duties is assigned in this line of work when you go talk to legislative staffers about this stuff also means getting weird bills and trying to help them resolve them. And we started seeing this pattern of legislative staffers having these weird unexplained bills that they thought should have been covered completely at no cost to them because it was for preventative services. And under the Affordable Care Act, this is supposed to be covered at no cost to them, but they were getting charged. And they were like, can you help us navigate that? So we went and we started talking to the employers and the insurers and saying, hey, what's going on here? Why aren't you guys covering this stuff like you're supposed to? The law says you have to. What's going on? And they started telling us that there's this new type of billing that's coming on. It's becoming more prevalent when we see consolidated entities buying up physician practices. And it is this type of facility fee. And part of the billing confusion that Christine was talking about earlier is literally on the claim form, that bill appears as though it's coming from a hospital main campus. But if you went into one of these outpatient departments, it's off campus, the insurer doesn't know that that bill was tied then to this doctor bill that they got. And they're not able to link those forms together and say, this was for the same event. And this part was preventative. So yeah, we covered that out of pocket, but that facility fee comes through. They have no way of knowing that they have to link that as preventative. And so that started us down this rabbit hole of looking at this issue and seeing it as this consumer facing, we need to protect people from these surprises and make sure that their bills are covered at no out of pocket like the AACA requires, but also this broader issue of it's an incentive for vertical integration and trying to contain the entire cost. So it's a twofold issue. But that's how we got into it, was legislative staffers had it happen to them. Most prevalently actually during COVID, when they would go get a COVID test and then get a $500 facility fee latched onto it.
And can you just say a little more about where that's taken you so far? Like where you having?
Sure. So we have a different set of political constraints in Texas than a lot of other places, and our options for dealing things have to be more market driven and indirect. We can't just go out and prohibit things or rate set. That is just a politically non-starter. But if we always talk about things in terms of creating a healthy marketplace, and a healthy marketplace is one that has to be informed. And here we saw that there was a information barrier that was preventing the market from functioning healthily. And that information barrier is primarily that the payers don't know where the service is being provided. So our approach has really been focusing on trying to fix that information barrier by requiring, there's a couple different ways you can do it, but making sure that the physical site of service is actually accurately indicated on that claim form has been our big effort going forward. There have also been some other efforts of making sure that if there are acquisitions that occur, that there are advance notifications that are given through that point. The one thing that we have been able to get through is even in free market Texas, there has been a strong appetite for just prohibiting the stuff for telehealth visits because it really doesn't make any sense at all.
Thank you. Thank you. Claire, would you want to pick it up in New York? Thank you.
So our story was a little bit different in that I came to New York about 3 years ago from Colorado, got some peaks here, and came. There we go, better. So I came to New York from Colorado and came knowing this was a problem and being really excited to go to 32BJ, which is known for having all their claims data in-house, and thinking, ooh, this is going to be great. And discovered that, first of all, our carrier, we're self-insured for about 200,000 lives, said, oh, we don't pay facility fees, you're fine. And then when we looked in our claims, we couldn't find them either because of all the things that Christine laid out. So it was like, but we know there's a problem, right? And so we went through a back door essentially and said, okay, if we look at we knew about this trend, right, of everything going from inpatient to outpatient, good. But we looked at the MedPAC subset of services and used it just as a trial and took those claims and ran those through our claims data set, and were able to show, we are actually seeing this reverse trend. And so it was nice to hear Christine talk about it. That had not sort of crossed my radar per se. So we had this reverse trend, which was something that was easy to explain to our board members. Like, that's just a bad business practice, right? But we also were able to model and say, if we were paying for those services at the average rate that we pay our doctors for the services, so we just said, this is what we pay now for the mix, but if everything were paid at the doctor's rate, we would save about $30 million. Now, $30 million, even though we spend almost $1.5 billion, is a lot. So some of you know that 32BJ removed a large, prestigious hospital from our network, and that saved us, to give you context, $30 million approximately. And that year, our union workers got their biggest raise in history. The management got a premium holiday, people got bonuses, and we were able to improve our reserves. So that's how big a deal $30 million is. And this would be without member friction, right? It isn't telling them they can't go to a hospital. It's actually protective. So that was formed the kernel. And so the legislation we did, we felt had to take on both the facility fee and the actual payment. So we say for essentially the MedPAC set of services and some of the additional already site neutral services, OT, mammographies, that kind of thing, that those can be done anywhere, but you can only charge the rate about 150% of the Medicare professional rate. So didn't want to get into the practice of medicine, but no matter where it is, and it applies to essentially the entire market except Medicare. So that means the uninsured, which if Medicaid bills pass, we'll have more of those, the small group market and the ERISA market. So we introduced legislation in Albany this year, the Fair Pricing Act, and we had a lot of doing this, and we got lots of opposition, but also amazing support, lots of stories, lots of activity. And then the big, beautiful bill passed, and that kind of took the wind out of the sails because it's scary, anticipating what will happen. So we'll go back to the well. Next year, we're talking about how we pivot, and we can talk about that more in our discussion. But that's our New York story.
Thank you so much. I just want to, I want to pause for just a second to make sure I understand the analysis that you did, because I'm slow. And to ask, so you analyzed the claims that had come in, and you separated,
You want me to start? Okay.
like I'm 5.
So we took that list of services.
Yeah.
Right? And we said, what are we paying right now? And that was a mix of office visit, crazy hospital outpatient department, but you can't actually always find the facility fee in those bills.
Yeah.
So we were just taking what we paid. And we said, if we took all of those claims and instead paid the average of what we were paying in the outpatient, in the doctor's office.
Okay.
So essentially we repriced the ones that were being done not in the doctor's office at the average rate in the doctor's office. Because all of those really should just be being done in a doctor's office. And we said, that's essentially what would happen if you didn't have that price premium that can be facility fees, it can be the higher marketing power, market power, can be any one of a number of things. But since you can't really find the facility fees always, that's what we did. That's how we got our roughly $30 million.
You kind of separated by who the biller essentially was. Was it a doctor's office billing as a medical practice, or was it a hospital?
Well, essentially, since you don't always know, we just took all of the procedures that had those codes and priced them at our average doctor's rate. So it's a back of the envelope,
Yeah.
but it helped us make the case that, in fact, we do have a problem because we didn't know we had a problem otherwise.
Yeah.
So
Thank you. Thank you. So I want to ask each of you to tell me about something that you learned in the process of getting to where you are, where it was like, I didn't know we had this issue, that you found a way to kind of at least take a next step toward moving past it.
Yeah, I would say for me, a huge learning was making the connection between this problem and policy and concept, which I think actually one of the things about it is that it's easy to understand in concept. Consumers can easily grasp that idea of why should the exact same service cost such a different price just based on hospital affiliation. But taking that kind of intuitive understanding and translating it into a definition that works in policy, and particularly that works in kind of data analysis, was a big learning for us. And I say that for anyone who's new or coming into this topic. I spent a long time feeling like I was the only person who didn't understand that connection. Like, is there a specific set of codes that when we're saying facility fee, we're referring to? And so I think kind of coming to a definition, which was an experience for us, but I also think collectively kind of states working on this have gradually moved more towards using this understanding that Christine described of really focusing on these 2 different claims forms and sort of defining facility fees as that institutional billing was really useful to us to kind of land on that and share it. But I think the piece that complicates that a little bit is, of course, those institutional forms are used in lots of different contexts and settings. And there's many where I think most people would agree it's appropriate. If someone is inpatient or having a really complex surgery, we understand the use. So I think also moving from a conversation about facility fees are bad to a conversation about when are facility fees appropriate or inappropriate, has kind of been helpful to us in, again, clarifying this issue for ourselves in thinking about policy solutions, but clarifying it for our legislators and others who are part of the policy conversation as well. So.
If I can piggyback off that, the definitional issue for us was also a problem because I encountered this thing that I had never heard of and came on to, and now I know more than I want to know about it. But the corporate practice of medicine restrictions in Texas, Texas has one of the strongest corporate practice of medicine restrictions. And what that basically means is that if you are a corporate entity, you cannot take a cut of a bill that a doctor provides. And so when we were looking at this issue, our first thought was, okay, let's take a look at these sorts of services and the specific codes. Let's say you cannot charge a facility fee for the types of services that should be being performed in this doctor's office. And by the way, hospital or owner of the facility, if you want to get paid, why don't you just take a cut of the doctor's fee? Like that's a private negotiation between y'all. You go figure that out amongst yourselves and keep this simple. We'll just have one bill. And the definitional part of this is that the hospitals would say, well, the term facility fee is meaningless because really the facility fee is just the way that we get paid. And there was this divide and we didn't understand it for a while. And they were coming at it from the perspective of, no, they literally cannot. It is illegal for them in Texas to go take a cut of that physician fee. And the facility fee was just how they were getting paid. So we had to come up with alternative arrangements and strategies to do that. But part of that was, what is this definition? One of the things that we learned this session is that the hospitals refer to the problem as their two-bill clinics. And I kind of like that term. So we've started using that as well. We call it a two-bill clinic. That's really the issue is.
Well, I want to ask Charles what he did about the two-bill clinics, because we run into this
Oh,
also.
sore spot.
Because in New York, there are integrated clinics that, were originally created to serve mostly the Medicaid population. They get all sorts of state bennies and subsidies. And they say, you know what, if you don't let us, we don't bill for those services, and you get respiratory therapy and OT and all these things in this clinic. And the only way we pay for those is the facility fee. And why would you want to deny people that wonderful integrated care? And so that is the argument that comes up. So we could talk about what we're trying to do, but I'm curious as to what your
The approach that we wanted to take there, and I will just be upfront here, we were not able to pass a bill in our legislative session that just ended. Interestingly enough, we had reached an agreement with the Hospital Association. We had reached an agreement with the Rural Hospital Association. We had reached an agreement with the Teaching Hospital Association and had a compromise that we thought was really good. And a couple of our large nonprofit hospitals went rogue and ended up blocking it through political maneuvering. But it was outside of the normal opposition that we had. But the approach that we were taking to address that was to empower our private payers with the information to solve it. Now, that's not going to solve everything. There are going to be cases where the market leverage is still going to allow them to charge higher amounts. But it was a starting point that at least in areas and metro areas where there was enough negotiating leverage, that this could become part of their contracts. And we talked to a number of the insurers. They said they actually had this information in their contracts and these clauses in their contracts to prevent this sort of stuff from happening. But they literally did not have information on the claim form to be able to enforce those contracts. So what we wanted to do was two approaches. One was require every single provider, including a facility, to get their own unique provider identification number. So there's a NPI is the term here, but basically it's your serial number that goes on the claim form that says exactly where this would be. That was a little controversial. There was going to be some implementation difficulties that I can get into later, but the other one was a site of service modifier. And this is okay, you put on your own identifier and then say, okay, but there's a modifier at the end that says this was not provided at our main campus. This was actually provided at an off-campus clinic. That leaves a couple of holes, but it solves, we think, probably about 85% of the claims would give enough information to the insurers to be able to address it that way as well.
I think the concept of perfect not being the enemy of good is important there. So we ended up exempting out our rural hospitals, some of our critical access hospitals, et cetera. But in all honesty, those hospitals don't have the resources to be doing a lot of physician acquisition anyway. And so it felt like a reasonable a reasonable compromise. But by setting that price cap and essentially requiring that that is all the hospital can charge, it has to be in the contracts. That was one of the ways we tried to sort of get around the facility fee. We did find out from one of our hospitals that we have a ban on facility fees for preventive services. And we asked, well, how are you doing that? They're like, oh no, we're still charging. And we interpreted the law to mean we can't charge the individual. We just charge you. And the law is loose enough that as we looked at it, we were like, damn. So, you know, that needs to be tightened up. But again, it's a little like whack-a-mole.
I feel like my biggest question at this point is, you know, you've been learning things in your individual states and you've gotten into lots of details. What have you learned that where you're like, you know what, a kind of national tweak would be helpful? There are limits to what states can do. And, you know, you're here in DC today, like what's a thing that you've learned where you're like, this might be, you know, if we could, addressable. If there's one thing that the federal government could do that would make what we're doing here a little more effective, what might that be?
Just one?
Well, let's start. As many as you want, but like,
To my mind, this is an issue that is impacting people. It is a real issue, but it is also a symptom issue. And the symptom is one of the larger consolidation. And so Claire has talked about how the prices are higher, regardless of whether you're getting one bill or two bill. The prices are higher when the hospital owns it. And that's a consolidation issue. But the incentive for the consolidation of those primary care clinics is coming about because of Medicare's not doing site neutral payments. So if there was a site neutral policy, that would start to reduce those incentives for consolidation. The other thing is if they were to require every single facility to bill with a unique NPI, that would really help us out.
I would echo the importance of Medicare doing it because as Medicare goes, so too go many of the payers, the commercial payers. And so there is legislation, as Christine talked about, but it also requires then the hospitals to put in place the mechanisms for addressing these issues at a larger scale. And that's good, right? Because that way we're not all dealing with it individually. And it's amazing to us. We look at the arguments that the hospital associations make around the country, and they're really pretty pathetic, but they work at each individual state, right? I mean, they're really not even very good, but we're all fragmented. So
and the worst of those arguments is, or the worst are,
we have to do this because nobody pays Medicaid and Medicare don't pay us enough. And it's the argument they make for every single thing that you try to tackle with respect to hospital prices. And we did a calculation. Again, we're good at back of the envelope. And don't tell our analytics team I just called it back of the envelope because they'd really kill me. But saying, okay, let's go with what the hospital association says on all their public speeches about we're underpaid by 18%. And we know you have this much percent Medicare and how much are you losing on Medicaid? You know, the data's out there, and basically backed into a calculation and said, okay, if we paid you 100, I think it's 140%, Misha and Jessica tell me if I'm wrong, but that's ballpark, 140% would cover that shortfall. So 150%, right? But it's always that argument that we have to because we get so shafted by Medicare and Medicaid. And hospitals will go out of business. And an individual, this is the argument I always heard in Colorado, the hospital is the largest employer in a lot of rural mountain towns. They'll be shut down. People will lose jobs. So hence the carve out of rurals and some of those to try to, and the safety nets, hoping to divide and conquer or at least neutralize.
So we definitely get we're going to go out of business a lot. The other one that we heard was there is a desire to have convenient clinics. And if we're going to have this increased focus on preventative care and getting folks in, and we want to have care done in the non-acute setting and the non-intensive setting of the hospital, the only way that these clinics can survive is if we're allowed to do this. And so the only way that we're going to have these clinics established in certain communities is if you allow us to exploit them financially.
Just a quick additional thought on the federal work. I totally agree with Charles and Claire on their priorities. One smaller, maybe smaller thing I will say that's a challenge across a lot of health policy work at the state level is ERISA preemption broadly, but very specifically in terms of submission of claims data to our all-payer claims database because of a Supreme Court decision. Large self-employed companies don't need to submit and their TPAs don't need to submit data. So we're lucky in Maine, we actually have one of the more comprehensive data sets, but it really poses a challenge with questions like this when we're trying to understand comprehensively what's happening in our state. So I would love if someday there were a legislative fix for that so that we could require that data submission and get a more comprehensive view.
Thank you so much. We're at the time for me asking questions. It's time for questions from you. Please go ahead and someone will bring you a microphone. I see someone's hand over there. There are people with microphones.
Hi there. I'm wondering how the panelists think about the price transparency data that has been mandated to be available in the past few years, and whether or not that holds any keys for employers to be able to see how these facility fees are interacting with their claims. So this is just an open-ended question, I suppose.
One thing about the price transparency data is it doesn't include professional fees. So you're missing, you end up missing half the equation, if you will, because you don't get to see the provider counterpart. So that's the limit. We use the transparency files for a lot of things, but it hasn't been as useful in this case.
The other thing I would say is that the price transparency files are helpful for knowing what the price is going to be if that thing is billed for. A lot of times it is the operationalization, there we go, of those prices and when they will be applied and when they will be billed. And there is maybe not an understanding or expectation that a facility fee coming from the main campus is going to be billed for services that are provided at an off-campus facility. So understanding how those prices, when they are going to be applied, is as much a picture as understanding what those prices are.
We covered it.
I see a hand over here.
Thank you. I'm wondering what has been or could be done to make this more visible and understandable for consumers. I've gotten bills that were multiple charges for the same visit, and it took me multiple calls to figure out that it was a facility fee, thanks to Christine's work. And then multiple more calls to figure out what the policy was. Is it for every visit, once a month? So what's being done to help consumers understand their charges and maybe engage in this debate?
I can take that one. I will say part of what did pass through our legislature as part of the debate over the last few years was a public posting of information requirement. I think there's limitations to that. I know we all, when we go, we get a little packet of paper and often don't read through. And I think the translational piece is important. I was going to say something we didn't talk as much about, and I think particularly given that Claire is thinking holistically about the total sort of price or spending aspect of this work, is there is a point, I think, at the insurance level where there's an opportunity to at least shield consumers from the impacts of these facility fees a little bit. So something else we did when we were analyzing was try and take a look. It's hard to do looking at all plans, but we kind of examined plan design structures in our state and looked for areas where facility fees were sort of carved out and treated differently for purposes of out-of-pocket charges for consumers, and didn't find a lot of that. I think I have seen examples of that in other states. So that's one thing I can say. I think it's a double-edged sword a little bit, because I understand why some carriers are wanting to maybe use that as a tool to direct people to settings where the cost is going to be lower overall. But it's one idea that's feasible or can be done to kind of create insurance design structures that ensure that there's less kind of exposure for the consumer to the cost, though options there are limited. Don't know if others have better ideas.
This is more about generally educating, but we did, in knowing that there'd be opposition to our bill, we commissioned a statewide survey and explained how this works to consumers, and that it was what the legislation would do. And overwhelming Republican, Democrat, red areas, blue areas, people supported this and said, this is just crazy. And that was very powerful for us at the legislature because it kind of, the goal is to take it away from being a red issue or a blue issue, et cetera. It doesn't necessarily get to what a consumer does when they get it, but did a lot to sort of try to raise awareness. New York has legislation that requires some of that information, and you have to give it to the person before they have a service, et cetera. But it is complicated to actually put in place, and they have successfully delayed implementing that component of it. And honestly, I understand in many ways, because it is the advance notification that's hard when you're coming in. So I don't think we've entirely cracked that nut, but people get this issue to Meg's point. So a lot of it, and podcasts, et cetera, but there's not, the only avenue we gave them in New York was come with us to support this bill. And our lobby days were amazing. And our union members loved talking about this because they got it.
There's a couple of advance notice things you can do. You can require public posting in the building itself that, you might be charged a facility fee at this building. One of the more interesting ones is if there is a acquisition of a practice that wasn't charging a facility fee that is going to, that they now have to send out active notice to all of their patients that their next visit is going to include that because of the acquisition. But I think that there is a limit to how effective a lot of these things can do. When you get stuff in the mail like that, a lot of times that just goes right in the trash. And so how wide is that getting out there? How much are people understanding that? The other thing that's a little maybe counterintuitive, and I don't know yet how I feel about this, but sometimes when you have these consumer notice things and they just get buried in a stack of papers with a whole bunch of other consumer notices, it almost gives them license to keep doing it. No, we complied. And I'm not sure that that's necessarily helpful. So I'm kind of two minds on those portions, but in almost every legislative effort to do it, there is some sort of consumer notice in it.
More questions?
Thank you. Really appreciate this conversation. Megan, I think you talked about the conversation of what's an appropriate facility fee, when is it and when isn't. And I'm just curious, to me, the concept of having a facility fee, even in an inpatient setting, is interesting. When did that happen? Did we lose that battle of a transparent facility fee? Do we just have to suck it up and pay those even in a hospital setting? Or can we move to, build fees or codes that actually take into account the cost of being in that hospital for that particular day? So, I feel like we've almost just already accepted that hospitals should charge a facility fee and some places shouldn't. But has there ever been a discussion about whether it even should be charged in the hospital?
That's a tough one for me to answer. I think we just take our cues to some extent from Medicare and sort of the origin of this work. I will say, and we bring this up when we're talking about it with folks in the state too, this is where the use of maybe professional fee or some of this language gets a little muddled, because it's not as though independent providers don't have overhead. They're building that into their fees. So I hear you in terms of, and I think that that's one advantage maybe to our law of sort of saying, just bill on one claim form or another maybe, and then we can at least sort of apples to apples compare. You're not thinking as much or dividing up charges across different claim forms. But in terms of, I guess, the terminology of facility billing or institutional billing, that is maybe where the work of states can only go so far, because we're sort of operating within this context that's so established on the Medicare side. But I totally agree with you, and I think Claire or others might have more to say about this underlying fundamental concept of why can we not just determine what an appropriate charge is and pay that for a service. I would love to move towards that, but I think that's a broader conversation, I guess, beyond specifically the facility fee one. I don't know if there's more you'd say.
No, I would agree. And it's sort of a take on what you can. And because this is a new practice we've seen as we trended looking at how it's changed over time, it felt easier to message let's nip this in the bud. It's a bad consumer business practice, as opposed to taking on the whole issue of whether there's a lot of issues to take on around that. But so it was really because we saw this as an abuse of what many in the industry have, for right or wrong, viewed as an acceptable component of inpatient bills, et cetera, so that you don't line item everything, right? There's kind of a blanket sum for a lot of that stuff. It felt easier to position.
If I could just add to be fair, I think to hospitals and other folks, there are contexts like emergency departments and coming from a rural state where I think there is an understanding that you need to support the availability of that facility, even when there's maybe not a volume of services or where the volume of services are variable. So I will just say, kind of in defense of the concept, that I think there are some situations like that where it's really different than operating a physician practice, where you can schedule your appointments and kind of adjust your staffing to the demand that you have. So I think that's one, understandable kind of argument in favor of a different kind of reimbursement model, or thinking about reimbursement differently for something like emergency services.
I think there's taking on a discrete chunk, something that is manageable. From my perspective, it'd be great if we had bundled payments and you paid one person, one amount of money for a set of fees, and all of the different providers, that was their job, right? You have a general contractor and they go subcontract. But now you're taking on an entire business model structure with every single provider group out there against you. And so by keeping it more discrete, it's a little bit more politically manageable. And then just in Texas, I mean, telling people that exactly how to run your business is probably going to be a little bit less successful than saying, here are some abuses and we're going to go after them.
Here.
Thank you. I just had a question for the panel. One thing we ran into in Colorado was when we tried to cap facility fees was comments from the hospitals about how many billions of dollars this is going to take from their revenue, and it was going to prevent them from, excuse me, accepting Medicaid patients, further narrowing the Medicaid network. And that was a fairly effective mechanism to get folks terrified about capping facility fees. And I'm just wondering if any of you have encountered that in your respective states, or if you have any thoughts on that aspect of this.
Just in terms of the financial difficulties, one of the things that we've had a lot of success with is using the NASHB data set. There's a hospital cost tool out there, and they have this really interesting measure called the commercial break-even number. And what that does is it kind of evaluates this cost shifting argument that we hear a lot. And the cost shifting argument is that they lose all this money on uninsured and government payers, and therefore they have to make it up on these other sides of things. The commercial break-even median number in Texas, and what that number means is that taking into account all other sources of revenue, all other sources of expenses, and just looking at the commercial market, the median amount that they need to charge Texas employers basically to keep the doors open is about 115% of Medicare. And what they're actually charging them is about 250% of Medicare. That's a huge, huge delta. And so the argument that you're going to shut your doors for most of the hospitals in the state isn't there. And so what we did is we graphed this. We put it up, it's visualized, and you can go look at a metro area. You can go look at an individual hospital. And when they make these arguments, we're able to kind of respond, here's what the financial reality is in this area or in this hospital. And let's put the data out there and see how you respond to that. So that has been effective. It's not a direct response to, okay, this is going to cost us $9 million, but it does change the narrative about where are there financial difficulties and where are there not.
I think we're close to time. I want to have this one last question. Who makes that data available? Where do I get that?
NASHB, so the National Academy of State Health Policy. And so if you Google their hospital cost tool, that's out there. We visualized it in Texas by congressional district, which was really powerful. And if you reach out to me, I can put you in touch with the people who did that if you're interested in doing that in your state.
I'll email you about that.
It's a great data set.
Yeah.
We also worked with Brown University to do some modeling in the different areas, again, to just be able to illustrate to legislators, this is really what it means. And yes, this hospital may lose this much money, but they have $10 billion in cash reserves, and Medicaid represents 1% of their population or 2%. And so let's really look at the numbers. So but it means really responding each time to enough to have them start to look not credible.
Mhm.
Thank you so much. I've learned so much. I have lots more questions. Thank you so much for doing this, and thanks to Georgetown for hosting it.
I just echo the thanks for Dan and our panel and for everyone who is here with us today. I hope you all have learned as much as I did from these conversations, and you're taking away a better understanding of possible outpatient billing and the mix of opportunities and challenges we have in making the system work better for everyone. We will be posting the video on our website soon, and we encourage you to share the recording with your colleagues who weren't able to attend in person. And expect more events on cost containment from the CHIR team later this year, both online and in person. Look out, for our emails in the coming weeks and months with those invitations. Thank you all. Have a wonderful rest of your day.